The broadcast is now starting. All attendees are in listen-only mode.
Good morning to everyone who's logged on, and also good morning to everyone who's made the opportunity to come here today. I appreciate you showing up, and we're going to have an interactive discussion on stroke. So for those of you listening in my ear that are in the webinar, there's about 30 logged on, but the intention is that we're also going to use this recording for the spring CE for the different paramedic services that actually transport in the Southwest to stroke centers. Need the paramedic prompt card. And as you know, the Ministry of Health actually have released the paramedic prompt card, so today's purpose is to actually review the prompt card and what has changed versus what is new. So thanks very much for making the drive in and coming. I'm just having some technical things in my ear here, and now we're ready to go. If you have any questions here today while we're talking, I'd appreciate if you just put your hand up, ask the question. I'm going to repeat your question for the purposes of the actual recording. That way we can get it on the microphone, and then we'll answer it as we go. Dave Usage is also in the room here, our education coordinator, and Dave is going to actually take questions from the audience that are on the web and actually interrupt me occasionally with some questions, and we'll also answer those as well. So it's going to be quite interactive, both from a local point of view, but also from a web point of view, so it's new for all of us. Without further ado, we'll start. So one second here. So the purpose of today is to talk about the new stroke directives, and the new prompt card for stroke, which actually has a time change in it, and also some of the logistics that surround the new prompt card for stroke. As everyone knows now, for those of you in the audience, you actually have a prompt card in front of you. Everyone knows that really what we're trying to do is we're trying to make sure that the strokes and the medical emergencies that they are addressed in a prompt fashion, in a consistent fashion, not just through the Southwest, but also through all of Ontario, and that's why we're here today. Because what happens in Ottawa has to happen in London, what happens in London has to happen in Clinton, what happens in different areas all throughout Ontario, we must follow the prompt card, and that way we have consistency. So our goal out of this standards document that came out, which is the best practice guidelines for stroke, is that we have a consistent and standard assessment by all paramedics in the field. And that not only includes following all the lists of indications and contraindications in the prompt card, but also standard physical assessment of the patients and also a standard history taking of the patients to make sure they actually qualify. We know that of all the patients we transport, about 30% of them ultimately, of the patients that are bypassed on the prompt card, about 30% of them actually get thrombolysis, so a very small percentage of them. And yet we're transporting large numbers of people to get that 30%. Of all strokes, only about 5% are actually thrombolyzed. So we're trying to be able to capture is the most patients possible to adopt this best strategy for stroke, which is thrombolysis and reperfusion. So we think about it like strokes are like brain attacks similar to a heart attack, and we know we want to get you to the hospital as soon as possible. So today we're going to talk about the pathway that actually we follow. We're going to talk about strokes and stroke mimics. We're talking about the different history and physical centers and all physical exams. We're also going to talk about what constitutes a stroke center, like what makes a stroke center a stroke center. So based out of this document, which is a long and exhaustive document talking about the entire pathway of care that a stroke patient follows, from their home to the EMS system to the hospital phase and the recovery phase, we're going to talk today about the pre-hospital phase, which is where we are specialists in, and we want to make sure that we deliver the standardized care as per this document. And the four goals of this are to transform stroke and prevention and care, to be able to make sure we have a standard approach to that. Disseminate the best evidence-based practice guidelines with regard to pre-hospital phase, which is what we're talking about here, and also be able to make sure that we stay up to date, which is exactly what we're doing here as well. Now, remember that it wasn't that long ago that we didn't actually thrombolyze strokes. And as you remember, strokes, unfortunately, there weren't many therapeutic options. You could have a large stroke, and actually still there were few therapeutic options outside of aspirin. So we'd admit you to the hospital, we give you your aspirin, and we hope that you recover through physiotherapy in time. Now we know if a certain percentage of strokes come in a time-sensitive fashion, we can actually give you a fibrinolytic, which actually opens up the artery and restores perfusion to your brain, and you actually will have, in certain percentages, a complete recovery of your stroke. But we know that there's a long list of indications and contraindications to that, and we know that there's some harm that may come of that if we give it to the wrong patient population. So we were trying to focus on what is the best, most important people to capture, and we have a very short window of opportunity to be able to do that. Much like many things in EMS, I think this is the future of EMS, is what we're doing is we're taking things that used to be done just in the hospital, in a time-sensitive fashion in the hospital, and moving it outside of the hospital and integrating EMS as a partner in what happens in the hospital. That way we can actually effectively eliminate the emergency department and delays that come through that and actually deliver you right to the model. So, for instance, you'll see that with stroke, we're actually bringing right to the neurologist from EMS, and you'll see that also with cardiac disease, we're bringing you right to the cardiologist in certain STEMI programs. We're also bringing you right to trauma centers in certain with new field trauma triage guidelines. So that's sort of the future of how we see EMS evolving, is you coming right to the most appropriate level of care. So one of the keys out of this best practice guidelines is basically to talk about how do we identify So we need to be able to adopt this standardized document for the local variations that occur, and that's sort of why we've had talks in Windsor, we've had talks in London, and now we're talking herein to be able to make sure that we account for all the local variability. With this webinar we're having today, it's going to be actually recorded and played in different municipalities like Oxford and Middlesex and Elgin, so that we have a standardized approach as well. So I don't want to just sort of focus on just the herein component of this today. Remember, this is a medical emergency stroke. Patients need to call 911. And for those of you that have watched a lot of TV, kind of like I do, you'll actually be sitting there and you'll watch the new advertisements come on. They'll be like, these are the signs and symptoms of stroke, and these are what you need to do with stroke. You need to call 911. We know that if you guys get there first and then you recognize the signs and symptoms and follow the prompt card and make sure they don't have contraindications, you can actually bring them to the closest appropriate hospital, whereas patients sometimes may get in their own vehicle and go to a hospital that's not a stroke center. Or they may actually not recognize they're unsafe to drive because they're actually having a stroke and be unaware of their disability or their lack of vision, and actually may harm themselves as well, getting involved in a motor vehicle collision on the way. So all of these things are important. As much as we want the patients to focus this on emergency, we want EMS to focus this as an emergency and use the appropriate screening tool. We don't want to miss one. We don't want to have it's such a small number. We don't want to have us arrive and then all of a sudden realize this person could have benefited from fibrinolysis and not transported them to the stroke center. And we've had a couple of cases of that as well. As we move down through our quality assurance program, this person could have gone to a stroke center and may have benefited from the thrombolytic. So we want to make sure we don't miss anybody. So once in the emerge, the reason for the time focus is that there's a lot of things that once they're in the emerge that needs to happen. We need to have a rapid CAT scan done. It needs to be interpreted. We need to make sure they get some lab work back to be able to make sure the clotting times are normal if we're going to give them a thrombolytic. And also we need to know all the different elements of history. And the history is super important because there may be some things that the patient's unable to communicate to you to make that decision, should I give you a thrombolytic or not. Things like, when was the last time they were feeling well? The fact that they wake up with this, they may have gone to bed feeling totally normal, but they may have like 6-8 hours of sleep, and then they wake up and now they have this disability. That doesn't qualify them. They need to be seen well. So sometimes the patients themselves are unable to communicate that. So you'd be talking to them, and they, because of their stroke, cannot express what's going on. So family members and other ancillary pieces of history are very important. Having the paramedics you guys stay around and actually address these things with the neurologist if it's possible, realizing all the different pressures you have to turn around and clear your stretcher and get out of the department and service another call. But these are very important things to be able to have that communication piece with the physicians. If they cannot rule out a contraindication or a reason to not give them thrombolysis, then they won't give them thrombolysis. And you'd hate to have a situation where you're withholding a potential remarkable level of care from someone that may benefit because they just can't get that last historical element. So all of these things all across Ontario are actually driven by the Ontario Stroke Network. And this is not a base hospital thing. This is not us as base hospital saying, you shall do this. This is developed by a team of neurologists and also a team of EMS agencies and also a team of physicians that have sat down and thought, what do we think is the best pathway for stroke? And all the different indications and contraindications that are listed on your card, they're not random. They've been debated and talked about for hours. Should it be a GCS 3? Should it be GCS 10? Should it be a blood sugar of 4? Should it be a blood sugar of 3? Should it apply to kids? There's all these different things that we've agonized over. But at the end of the day, and I've written this in my newsletters before, at the end of the day, all of that is lost. All that debating and hours and time spent in meeting rooms making sure that this works, all that time is lost if you, at the end of the day, the deliverers of the care and the people that use the prompt card don't understand the prompt card or haven't read the prompt card or are not familiar with it, when it's lost because we've just spent all these days debating it, but the end user doesn't know the card. So that's why days like today are so important. So I appreciate you coming. So now, one of the biggest things that we have in terms of patients is when they come into the hospital, we're trying to figure out, there's a bit of a gamble with this. It's not a risk-free therapy. Some patients will actually have bleeding because of the thrombolysis. So what we want to be able to do is be able to realize that we have to give them informed capacity and consent. We have to talk to the patient and say, look, there's a 30% chance you're going to have a complete recovery from your stroke. There's a 60% chance you're not going to have much of a recovery, and there's a 10% chance you could have some significant bleeding. And these are an important discussion to have with the patient. But if we cannot actually convey that to the patient and deliver that informed capacity and consent and explain the risk, then it's really hard to be able to deliver the care. So we need to be able to make sure that there's someone there that's able to take that history with them. And if you're able to transport based on your local policy and procedure, the family member or a patient that's around, someone around them or some other member of the family that happens to be there for responding to someone's home, that's also very helpful as well. Or if you're able to stay and speak with the neurologist when you get there as well, to provide that last historical element, that's also essential. Okay, now, one of the things I want you to understand as well is that since this is developed by everyone, developed by neurologists and also developed by EMS physicians and also paramedic services, I want you to understand why it is we focus on the timelines and why we provide quality assurance at the end of it. There's all these different timelines that get audited in all these calls. When a patient arrives at the stroke center, we actually get communication from the stroke center saying this patient arrived, they didn't meet the criteria because of this, the paramedic either didn't get that piece of history, or else this person arrived at this hospital but actually could have benefited from the stroke therapy having gone to a stroke center, so it looks like this prompt card was not applied. So we get that kind of material that's sent back to us, and that's why we need to investigate it. It's so important that I don't want you to feel like we're hassling you into the times or being able to be tracking you down, but these are things that we're put under pressure by the Ontario Stroke Network, so we need to be actually go through our own EMS database of calls that you do, and we're not trying to be on your tail, but I want you to explain that that's the network that we currently have, and that's why we follow these up. So when we look at different stroke centers, and I think that Huron County just opened Goderich is a stroke center now, and now you're starting to transport right to Goderich, and that's a big, big achievement. And it used to be that we only bring them to larger centers, the places that had the CTs, the MRIs, the neurosurgical backup. But now, because we want to get this care delivered to everyone throughout Ontario, we have a network through the Ontario Stroke Network of telestroke places where you can actually, they have a CAT scanner, and they actually have a neuroradiologist that can read the CAT scan, and they actually talk with the neurologist and walk through the delivery of the medication at smaller centers. And so that's imperative that we realize where our local stroke center may be. Certain areas of the north is actually, they're now developing CAT scan units all throughout the north now, and I don't mean just like the northern aspect of southern Ontario, but in the northern regions of Ontario as well, we're implementing CAT scanners as well. And that way, neurologists will actually look at the CT scan and talk about the indications and contraindications, and so will the neuroradiologists that are remote and looking at these CTs. So that's allowing all of Ontario to benefit from this care. So what makes up a stroke center and a telestroke center, and why we bypass other hospitals, I just want to go back to this slide here. So normally the comprehensive stroke centers are things like there's 24-hour neurosurge, there's established written stroke protocols. They have the ability to not only provide thrombolysis, but they also have the ability, in cases of bleeding complications, to actually provide neurosurgery. They actually have, because remember, a certain percentage of these strokes as they come in, what seem like a stroke, may actually be hemorrhagic stroke as opposed to an ischemic stroke, and so they don't benefit from the thrombolysis. They benefit from just the opposite, like some actual intracranial intervention, like an operation by a neurosurgeon. So therefore, it used to be that these are the main centers, but now as we're making up different stroke centers, they have not only do we have access to thrombolysis with CT scanners, they actually have the telestroke like I was talking about. But then finally, we have hospitals without specialized resources, and these are the hospitals we want to bypass to be able to make sure we bring you to a stroke center. Occasionally, you'll have patients arrive at these hospitals by themselves that we need to try and get transferred to another stroke center as well. So you actually, depending on your local agreements, may actually be doing the interfacility transport to get to a stroke center in a short amount of time as well. Now, what I want to talk about today is really that's the background. I mean, for me, that's sort of where we got to where we are today. Where I think is more interesting from us as EMS is how do we make our assessments? What's the exam like? What's the physical exam like in a stroke? And what actually is the definition of a stroke, and where does everything go? When I was a medical student, it was quite an awakening for me to actually understand neuroanatomy. And neuroanatomy is a really painful course. a year-long sort of process where every Thursday we took 3 hours of neuroanatomy, if you can believe it. I think that's changed now, but it was a painful, long year. So, I remember vividly one of my bell ringer exams where I sat there and they just kept throwing up slices of brain after brain after brain with different stains, and then every 90 seconds they would change the slide and say, what section of the brain is this? So for 3 hours you're like, I mean, I don't know much about the brain for 3 hours of like 120 multiple choice questions. It was super painful. So don't worry, nothing like that's coming at you. But there's certain key things that I think help you and guide your physical exam, knowing and understanding neuroanatomy. And we'll be talking about that here. So anatomy and physiology we're going to talk about. What are the signs and symptoms of acute stroke? We're talking about some of the stroke mimics. So some things actually look just like a stroke and seem like a stroke, and you may transfer based on the stroke, but they're actually not. And that doesn't mean you've made a mistake or you've not followed the prompt card. There are just, we recognize there are certain things that are mimics. It looks just like a stroke, and it requires a neurologist and a CT scanner to be able to differentiate that. So that's why the prompt card is fairly generic in terms of what the guidelines are, because every stroke is slightly different. We talked, I think I beat the history and physical assessment and being able to communicate that piece to the neurologist. I think I've beaten that to death. But we're going to mention that again one more time. And we're going to talk about what the documentation is like as well, what we need to document. So I think it's important when you look at the brain to realize that it's actually structured in different locations. Like there's different things in different areas that look after different things. So the primary motor cortex, this blue strip you see here, that actually coordinates your movement. Like that is actually what actually causes you to give motor. Now, remember as well, you have different areas as well, which is your frontal lobe, which is the area that controls your personality and also different things that make us us. Now, I think it's important. Did you guys take psychology or any courses like that? There's this guy that's named Phineas Gage. I remember this from my psych course. He's the guy that used to work on the railroad, and he took a railway tie to the head. And for some reason, someone launched it through his head. And he used to be a very mild-mannered, very affable, nice guy, very quiet, didn't say much. And then all of a sudden, after getting a railway tie through his head, he became a total jerk. And everything he said was basically like rude, obnoxious, and a swear word. And people are like, can you imagine how different that is? And it's from things like that, that primary evidence, that we realize that personality sort of comes from the frontal lobe. Interestingly enough, the back part of our brain, sort of occipital lobe and beyond the parietal lobe here, this controls balance as well as our speech and also our fine motor coordination. So sometimes in stroke, we typically see large motor weakness, and that's sort of what we're looking for. But yet again, you can sometimes have subtle strokes that affect people's balance and coordination. If you think about the thrombolysis or the life-saving therapy we're going to be giving, well, not life-saving, but the actual motor-saving things that we're going to be giving, it's a gamble like we talked about, and it's not without risk. So you want to make sure you're getting your biggest bang for your buck. So the neurologists aren't necessarily going to give the thrombolysis to someone because they're a little bit uncoordinated or a little bit dizzy or a little bit weak. They're going to do it because they're debilitated. They have complete loss of speech. They have complete loss of their motor ability on one side versus the other. So in that situation, you have a lot to gain by having the thrombolysis. And there is a small risk. But what you don't want to do is expose them to that small risk just because they're a little bit weak or a little bit dizzy. So although those ultimately may wind up being a stroke from more silent area on one side of the brain or one of these coordination areas in the back part of the brain, we want to make sure that the best bang for the buck is delivered, because this person will spend the rest of their life institutionalized, not able to move one side versus the other, or unable to speak. That's the person we want to be able to give the thrombolysis to, and that's why the prompt card is written like it is, looking for gross motor deficit or inability to speak, that kind of information. Remember as well that people have the right side of their brain controls the left side of their body, and the left side of their brain controls the right side of their body. And if you're right-handed, most people's speech center is in the left. So I always look at patients when they come in to me, and I'm like, okay, so I always find it kind of odd when you approach a patient with a stroke, and I always ask them, well, are you right-handed or left-handed? And if they're right-handed, I'm thinking, okay, their speech center must be in the left part of the brain. Therefore, if they're unable to communicate or having a hard time speaking, it must be a left-sided stroke, and now I'm looking for right-sided weakness when I'm examining them. And then I'm thinking, well, if they're right-handed and they have a difficulty with speaking, but they have left-sided weakness, I'm thinking something else may be going on, or maybe there's something I'm missing because this isn't adding up. Remember as well that patients may have neglect, and we'll talk a bit more about that, but they may look away from the side of their body which is actually not functioning properly, and they'll address you like this, and they'll be moving and obeying commands and speaking with you and following your commands, yet again ignoring this side. And they actually may seem quite normal to you for a while until you realize that they're unable to actually move this side as well. And patients, believe it or not, in certain types of neglect, ignore this side that's not functioning, not just from a vision point of view, but are unaware of it. So if you ask them, they feel fine. They'll say, I'm doing okay, things are good. And you're like, well, can you move the other side of your body? They're like, okay. But if you go to this side of their body, the non-functioning part of their body, you ask their name, they'll actually not even look over at you. They'll completely ignore you. So they'll be like, you'll say, Mrs. Johnson. She'll be looking up and looking more to the left, even though you're on her right, saying, Mrs. Johnson, and she's looking for where that voice is coming from. So if you go to their left, and all of a sudden they'll look at you and say, what's the problem? So it's remarkable how much someone will actually neglect things. And that may actually minimize someone's actually neurological findings, and you may actually miss the stroke that they're having. A good example of that was one time when I was a resident, I was in orthopedics, and I was taking patients down referral centers. So they came in with hip fractures. So a patient came in from a referral center, and I was assessing them at London Health Science Center as the ortho resident. And the family came in, and she definitely had a hip fracture. That's definitely what she had. And I'm like, well, how long has she, but I noticed as I was examining her, she was unable to move her right side. So I'm like, well, how long has she been unable to move her right side? I'm assuming she must have fallen out of her wheelchair or something like that. They're like, no, she can move her right side. Well, she can't now. And you examine her, she's completely unable to move her right side, and she has a right-sided hip fracture. And what had happened is she had a stroke and had fallen over and broken her hip. And so she actually made it through not only the EMS system for that referral center, but also she made it through the emergency physicians at the referral center and all the way up to me, the orthopedic surgeon who was the resident, and went, well, she does have a hip fracture, but she also has a stroke, and that's a big concern. You may have also noticed in certain places that you'll go to the mall and you watch patients. I do this a lot with sitting around in airports, not that I go to the mall, but sitting around in large areas. You watch patients walk by and you can sort of figure out their medical diagnosis. This has happened to me many times. You watch a patient walk by, and for instance, at the mall or the airport, they have a loss of their facial muscles on one side, so they're weak on one side. And that same side, their arm is flexed up and curled up, and it seems to be somewhat atrophic. But they're ambulatory. They're walking around like this. And if they're walking to the mall or walking to the airport, you look at the person and go, oh, they must have had a stroke. That same sort of thing will happen when you go to a nursing home. You'll see a patient that's in a wheelchair, and you'll think, well, why is that patient in a wheelchair? Because they seem to have their arms moving perfectly well, and their face doesn't seem to have any asymmetry to it if they're confined to a wheelchair. That's because they've had a stroke as well, but of a different area. And so if you look at the structure of the brain and the motor cortex, what actually happens is that some areas fed by certain arteries, which affect more legs and actually your feet, or certain areas affect more face and arm, and that's actually divided by the different arteries. So what I'm trying to say is that when we look at this diagram here, look at the temporal lobe and the central focus, what you will find is that there are areas in the left side there which is fed by the middle cerebral artery. And that middle cerebral artery here will affect mostly your face and arm. Whereas the anterior cerebral artery, which comes up actually along the frontal lobe and involves more of the middle of your brain, that actually controls most of your leg. So an anterior stroke gives you leg weakness. Dave, I'm just doing some interference in my ears. I just want to affect our recording because I'm hearing some radio music. Someone has radio going. I think maybe next door. Got it. Okay. So and then so that'll affect the middle of your brain will actually affect your legs. So that realize that when you look at someone, they actually be having a significant stroke, so that's why it gets them to move their legs and also their arms when you examine them. So this sort of explains the different areas of the brain as well as what specific things can happen. And specifically in the back part of our brain is also vision. So sometimes it can actually be very subtle. Not only is it balance and proprioception or fine motor control, but it also can be vision that's affected as well. So I always find it funny that the temporal lobe and some of the frontal lobe is emotions and stuff. So you'll see personality changes in people with multiple strokes, especially in dementia, which is a spectrum of multi-infarct dementia, where you have multiple tiny strokes over time that actually affect patients. We see that in emerge as well. You'll come in with your weakness or dizziness, whatever it is, and as part of our workup, we'll do a CT scan. We'll actually find silent stroke in many people. Even over the age of 55 or 60, actually some of them have subtle stroke in the deep white matter of the brain that we distribute to old age. So we actually don't talk about that. But they wouldn't, when we tell someone there's a stroke, they'd be sensitive to the fact that, well, you have had a couple old strokes, and the patients are like, you're kidding me, I've had a couple old strokes. And you're like, yeah, but that's normal, that's part of aging. These tiny, tiny little ones, obviously there's a stroke risk that we need to address as an outpatient, but really the ones we're talking about here that you want to be able to thrombolyze are the ones that have the big motor deficits as well. One of the things important to highlight as well is that we've had a couple strokes that have gone to stroke centers that actually weren't actually strokes. And what they were was they were alternate diagnoses that resulted in either low blood pressure states or else the patients were unconscious. And remember, this is a clotting of a blood vessel inside your head. So there's no one blood vessel inside your head that controls your blood pressure. And there's not really one blood vessel inside your brain, one blood vessel that controls necessarily your level of consciousness. Well, there kind of is, but it's deep right in your pons and deep in your midbrain. So if you're unconscious or you're hypotensive, chances are it's not a stroke. So if you have a low flow state, like a 30-degree heart block or a heart rate of 30, or maybe you have a ruptured AAA, you have a ruptured aortic abdominal aneurysm, and you have a blood pressure of 60, as you're not perfusing your head, you will look just like a stroke because you're kind of unconscious. You're not perfusing your head. So therefore, we actually will see focal neurological deficits because of that, because there's lack of flow to your brain. Very similar to hypoglycemia. You need sugar to metabolize, and so sometimes in certain types of hypoglycemia, you actually develop focal neurological deficits like motor weakness. And that's why we have built into the prompt card as well, your sugar as well, to look just like a stroke. So I mentioned the blood supply of the brain. There's definitely the middle cerebral artery here. You can see as it comes up, this actually perfuses mostly the motor deficits. So most strokes we get used to see, perfuse the motor cortex. Most strokes we get used to seeing are the ones that affect your face and affect your arm. That's because the middle cerebral artery is the one we mostly see. But the anterior cerebral artery, you can see coursing back up here, this actually feeds the legs, and that's why you get weak in that section and you're unable to walk. Remember that 20% of stroke is actually hemorrhagic. So clearly, you're not going to qualify for thrombolysis if you actually are currently bleeding inside your head. And that's why the time-sensitive CT scan is so important, because we want to be able to make sure it's not a bleed. And they look just like a bleed. Bleeds look just like a stroke, because they are a stroke of some kind. That's why we need to CAT scan and rule those out. Otherwise, we're going to make you a lot worse. Remember that amongst the ischemic stroke, it's not necessarily just the ones that create, you have the atherosclerosis and then progressively gets thinner and thinner and smaller, and then eventually you clot off that vessel. That's a thrombotic stroke. But you can also have, under the ischemic type stroke, an embolic stroke. And this is what we tend to see more in young people, where they have some vegetations on their valves, little blood clots or pieces of bacteria that grow in their heart valves, and they can actually break off and go up through the carotid arteries and affect it and block up an artery. They tend to be quite devastating. Large strokes, they tend to be quite large, sort of less blood vessels in the brain that get stuck. Unfortunately, we see that a lot with our IV drug-using population. When they're injecting things, they actually inject small particulate matter, and although oftentimes it gets filtered by the lung and captured by the right part of your heart, it goes to the right part of your heart, it goes to your lung, it gets captured. Occasionally, we'll actually a certain percentage of the population have what are called patent foraminal-valves, or small little holes inside their heart between their atria, which allow the small embolic things to make it from the right side across to the left side, and then they go up in stroke because of that. So we see that. Or else they develop bacterial infections on their aortic valve because of their IV drug use, and then obviously those can actually launch up and cause stroke. So when you see young people with stroke, 20s and 30s, it's most likely an embolic phenomenon versus a thrombotic phenomenon. And that's why, for one of the reasons with PEDS has been actually included on the stroke list, because some children actually have congenital heart disease, and they actually may have large holes inside their heart which allow different particulate matter to go up, and that causes a stroke in certain people. We also know that it's important to apply the cardiac monitor in certain of these patients, or all these patients, because of the fact that certain patients will have atrial fibrillation and actually develop clots because of an irregular heart rate, and that actually causes their stroke to go up. So sometimes when you see a stroke, look to their brain and realize that they may actually have an embolic type stroke. So regardless, 80% of them are caused by thrombosis or embolisms. That's the ischemic ones. And these are the ones we want to open up, and these are the ones that will benefit from thrombolysis. Now, TIAs. Now, TIAs are very are brief strokes. So people come in with exactly the type of stroke, but the stroke seems to resolve without a neurological deficit by 24 hours. Now, I'm sure you guys have seen lots of TIAs. We see lots of TIAs, and there's actually a lot of a lot of literature and education done to the public, where actually now patients are coming in and saying, "Do you think I had a TIA?" And so much stuff gets misdiagnosed as a TIA. So as I mentioned before, it's unlikely to actually lose consciousness with a stroke. So when someone collapses and regains consciousness, it's probably not a TIA. But oftentimes that gets misdiagnosed and sent to the neurologist as a TIA. Regardless, I don't think in this situation we're going to be dealing much with TIAs because if they're going to qualify for the prompt card for stroke, they need to divert to the stroke center. And if they resolve en route, well, then maybe it is a TIA. But there's no way to tell ahead of time who are the ones that are going to respond and actually get better. So that's why we have a special language in the prompt card which talks about what happens if they start improving en route and you still continue to go to the stroke center because we're not sure how much they're actually going to improve. Remember that in order to lose consciousness, you have to have a stroke or a bihemispheric insult, meaning you have to have something that affects this side of your brain and this side of your brain, or deep within your brain, in your brainstem or your pons. So if you're unconscious, it's very unlikely to be a stroke. So what are the warning signs? And this looks just like one of those ads you see on TV. What are the warning signs of a stroke? Well, their weakness, the difficulty speaking, obviously the vision problems. Headache or an unusual headache is a risk factor for stroke. Obviously, that's one of the historical elements you'll see. That usually fits more with a bleed. The sudden onset of a severe, terrible headache, that's usually more of a bleed. Dizziness certainly can be a stroke, but it's more the posterior aspect of your brain we tend to see. You get this intense vertigo that's classic for some of the posterior type of strokes. Certainly a loss of balance as well as classic for that. Now, remember I mentioned before that there's a left and the right hemisphere, and they control opposite ends of your body in terms of your motor cortex. But there's also different things. If you affect the dominant hemisphere or non-dominant hemisphere, one side of your brain is more concrete and more mathematical and more objective, and one side of your brain is more spatially orientated and also more artistic. So depending on what side of your brain you affect, you may seem slightly different. So regardless, the stroke protocol, prompt protocol speaks about motor weakness, and we'll get to that as well. But if you notice that when we examine patients, the first thing we do is, one of the first things we do is look at their face and see if there's any asymmetry. But it also gets you to put up your arms like this, and it's called the pronator drift, and we see if your actually arm is one weak or the other. And I think that one of the important keys to note with this is that it takes energy to actually do this, to actually put your arms palms up in the air. And the reason for that is that although this is called anatomic position, we look at those diagrams of people's anatomy, they look like this. It takes energy to actually pronate or to supinate your arms like this. So what happens is that if you're actually weak, what you'll do is you'll actually start to move your hand like this and actually pronate, so actually curve your arm over like this. That pronator drift, this movement like this, is actually one of the first signs of weakness you'll get. It's actually not a drop. It's actually the fact you'll actually move like this. So the reason for that is that you don't see people walking down the road like this. We walk down the road like this because it's the natural resting position of our hands. It takes a lot of energy. If it didn't take energy to do this, we'd walk like this, but we don't walk like this. If you do walk like that, well, you're doing that intentionally. Now, so a right-sided hemispheric stroke, you may have difficulty with space perception as well. You may have difficulty with your left-sided weakness. You may neglect the opposite side. You'll have difficulty with impulse behavior and poor judgment. You'll have a loss of flow of speech. But in the left side of your brain, a left hemispheric stroke, you'll have a difficulty with actual expressive aphasia. You cannot say anything. You're basically unable to speak. And also you may have a receptive aphasia, which means that you hear noise. You hear people talking, but you're just unable to assimilate what they're saying. I heard on the news there's a senator in Phoenix or in Arizona that was shot, and she was shot in the brain. And it's interesting that she was shot, I believe, in the left side of her brain, so she's really having a difficulty with speech. But she's actually able to speak with occasional words that are stored in different areas. So these emotional words. So when they brought her to the shuttle launch, apparently, on the way to the shuttle launch, she said they told her, you're going to go to the shuttle launch. And she was able to say awesome or great or fantastic or those types of things. That's stored in different areas. Also, swearing is stored in different areas. So you may be able, ironically, you may be able to see someone and go, how are you doing? And they're unable to speak, and they're able to speak. And so you'll show them, like, what's this? And you'll show them a pen. They'll be like, Then they go, damn. And you're like, no pen, actually. But they're frustrated that they can't actually say the word, but they're able to say different words. So it's amazing the different rehabilitation that people go through stroke. But I tell you that because it's also important to realize that when you examine patients, you may miss the fact that they're actually able to say an emotional word. You may think, well, they're able to speak. But it's because they're responding to pain, and they'll say, ow, or they'll say, that hurts, or you're a jerk. But they won't be able to say, my name is Fred, and I live here. So their normal flow of speech may be different. So it can be quite subtle. Now, different stroke mimics. I don't expect that we get all these things done as EMS. And sometimes emerge misses these as well before referring them on to neurologists, because it can be very difficult to differentiate these pre-hospital. But also in a short time frame you're given if they're going to qualify for thrombolysis for stroke and you're going to activate the stroke prompt protocol, you got to get moving. You have a timeline that has to happen. So these sometimes are mimics that actually cause motor deficits that you may think is a stroke and actually improve en route to hospital, or they wind up not getting thrombolysis because they're actually stroke mimic. One of them is post-ictal deficit. What that means, you've had a seizure, and after your seizure, you're actually weak on one side. You can actually look completely like a stroke, like hemiplegic, and that progressively improves. That's got a name. It's called Todd's paralysis. And so we'll see patients post-ictal, post-seizure, they're actually are weak on one side that improves. That's why one of the reasons that seizure is actually a contraindication on your stroke pump protocol. We'll see people in sepsis or severe systemic otherwise unwell or severe febrile states that actually seem to have difficulty with speech or difficulty with coordination because they're just sick. And so they'll actually mimic that as well. If you have a growth inside your brain or you have an abscess or a tumor, these things can press against your nerves or press against your brain and cause swelling in certain areas that affect your ability to move. So we'll see people with brain tumors that walk in, and it always amazes me what actually walks in the emergency department. I've met patients who are actually unable to move their arm. It's because of a slowly progressive tumor inside their brain, or it versus an old deficit. And that's where the family history or someone had, if the patient's unaware of the stroke or if they're institutionalized, someone had to recognize that something has changed to activate you guys. Otherwise, you'd still be sitting there at home. So therefore, whatever that new change is, that's the key historical point you got to pick up and recognize and be able to communicate that to the person that's trying to make the decision, should I thrombolize or not. If they've had an old stroke, maybe it's because they've actually been told by a doctor, like I talked to you about earlier, I came to the hospital, he told me I had a couple old strokes in my brain, but he was walking around normally ever since then, and now all of a sudden this represents a huge change. They're completely weak, they're unable to move their face, they can't speak. That represents an acute change. That's the kind of the history you really need to know. Clearly head trauma, well, that makes you much more concerned this could be a bleed, especially the patients that get, you heard about, I remember playing baseball as a youngster, and they said, you get hit in the head and you get hit in the temple. You've probably heard the expression getting hit in the temple. Well, really, your middle meningeal artery is right here, and then you will actually, I'm pointing to my side of my head, in the temple. So when you get hit like that, occasionally what happens is you rupture the artery because you have a linear skull fracture, and then the middle meningeal artery is embedded in the skull. You rupture that, you get an arterial bleed. Initially, you feel unconscious, then you get back up, and you feel fine. Your brain compensates as that expanding hematoma gets larger and larger, and then you eventually, over the next 6 hours, develop unilateral motor weakness, you blow a pupil, you get facial weakness, and then you seize, and then it's because of this shift to raising finger pressure. That's called an epidural bleed. So head trauma certainly looks just like a stroke if you get it at the right time. We see this a lot with the elderly population, and this is why no services are so dangerous in the elderly that have a fall. You go to a nursing home, someone falls, they whack their head, they're on Coumadin, they have a minimal head trauma, you get them back up, they seem fine. Remember, their brains are, if you're 80 or 90 years old, it's somewhat atrophic and actually smaller. So there's a lot of room for that brain to move inside your skull. You smack your head, all of a sudden you move the brain this way, you actually tear the bridging veins inside on top of your brain, and it starts to bleed at a low pressure. That low pressure slowly accumulates. They seem fine, they're fine for days. Then about 3 or 4 days later in the nursing home, all of a sudden you'll find that now that bleed has continued, and they're actually now pressing against that side of the brain. That's called a subdural hematoma, and that is causing now pressure on the side of the brain. Well, what do they look like? They look like they're having a stroke. They have weakness on the contralateral side. They actually may have weakness in their face as well on the contralateral side. and these patients arrive, and we don't have a good history for the fall. It didn't happen today. It happened 3 other days ago under someone else's watch. There's no incident report or anything like that. So these patients show up and actually have a large subdural hemorrhage. We've seen that as well. So I don't expect you to make those diagnoses in the field, but these are things when sometimes you bring them to the hospital while we don't thrombolize because they actually have some alternate diagnosis. Hemiplegic migraine is actually on there. I saw a case like this when I was actually a neurology resident doing my residency in emergency medicine. We rotate through every discipline, and this is clearly a diagnosis of exclusion. The 26-year-old woman came in, and she actually was hemiplegic from a migraine headache, and actually when you treated her migraine, her weakness got better. That is a diagnosis that's made after like multiple MRIs, and it's not a diagnosis they made in the field. Okay. Let's talk about the prompt card. Now, for those of you in the audience here, we have the prompt card in front of you here, and so it walks through a series of steps that we make to make a decision as to who we should thrombolize. And this is not, as I mentioned before, this is not a base hospital thing. This is created by the Ontario Stroke Network. So it actually may be, at some level, when this is being created, that I disagreed at one point during one of these meetings about some of the points that are in here. But nevertheless, this is the consensus. This is when you make a decision as a team, you have to be able to put your own personal viewpoints aside and go with what's best for the team. So this is a consensus and a collaborative effort by Ontario Stroke Network, EHS, the Ministry of Health, and also the Medical Advisory Committee of the Ontario-based hospital program. So that's what we have in front of us here. This is not just us as the Southwest Ontario Regional-Based Hospital Program saying, this sounds like a good idea, let's do this. So the first step in it is, do they have unilateral arm weakness or drift? And they must have at least one of the following: slurred speech or inappropriate words or mute, or unilateral facial droops. So they must have one of the first 3 findings. Plus, we need to know that they were seen well, and they're at least within 3.5 hours of being last seen well. And then there's a bunch of contraindications that follow. So let's walk our way through this. 52% of affected stroke patients arrive to hospital by ambulance, and currently the last time seen to normal in the emergency department ranges from 1.7 hours to 8 hours. So unfortunately, if you look at where we fall the most as EMS, it's last seen well, because everyone wants to do the best job they can for the patients to make sure you provide them with every opportunity to get better. But we actually will harm them if we thrombolize them outside the time window. If you're 6 or 8 hours out or 7 hours out and we use a thrombolysis, the risk of bleeding increases remarkably. So remember, even though they wake up in the morning and they felt well when they went to bed, that doesn't qualify them. It has to be that they're up, they're having their coffee, they're talking to their partner, they're walking around, and all of a sudden they have the stroke, and they was witnessed. They're like, I saw you're normal at 7 o'clock. It's 8 o'clock now, you're unable to speak. This clearly is a new change. These are the patients we need to address and qualify. Clearly, we don't want to, although the benefit of thrombolysis is there, we don't want to, in an effort to get you to the stroke center, lose you. So therefore, if they're unstable, if they have airway or breathing concerns, if they're unstable at any point, these are patients that we need to bring them to the closest hospital. It doesn't make any difference. You get them to the stroke center, but they're unable to breathe and they don't have an advanced airway. And remember, too, that if you have someone that's losing their airway or profoundly hypotensive or unstable, it probably isn't a stroke. There may be some alternate diagnosis that's causing this. There's not, yet again, there's not one blood vessel inside your brain that you ping off, but all of a sudden, now you're hemodynamically unstable. So the last seen normal date, this is a super important time. So we need to know that. If it's unwitnessed, well, the question is, well, who is the new person that's calling? Is it the patient themselves that are calling? Well, then they must be able to tell you when the last time they felt well was, and that they were well and up in the middle of the night, or up like 2 hours ago, or up an hour ago, and were totally fine, and now they're not. One of the questions that keeps coming up is palliative status, and what constitutes palliative status? And this is a really difficult decision because it's kind of gray. Like, what is palliative? So is palliative care the fact that you are now at home, you have an expected death because you have metastatic terminal cancer, everything that can be done is being done, that we're taking off all your medications and you're getting like a morphine infusion? Is that what's happening? In that case, that person's probably not going to benefit from having thrombolysis. That probably is not the patient you want to be transferring to a stroke center. Or is it someone that is institutionalized and has a DNR? Well, if you have a good quality of life in your institution, you're up, you go and watch all your television, you do whatever you do in your nursing home, I wouldn't say that a DNR is a palliative care. In fact, it's important to define what a DNR is. A DNR is simply do not resuscitate. So if I die all by myself, if I have a cardiac arrest, do not resuscitate. But if I don't die, do everything you can for me. So it's not a DNT, like a do not try or do not treat. It's a do not resuscitate. It very well could be that I'm a DNR right now. I mean, if I keel over right now, my end-of-life thing may be don't put me on a machine, don't do CPR. My likelihood of survival anyway is only 8%, so just leave me be. But that doesn't necessarily mean if I have a stroke, you don't thrombolize me. But so palliative status is gray. And if you're having a hard time making that decision about your palliative, whether or not it's palliative or not, err on the side of treatment. Bring them to the stroke center if you're not sure. But at the same time, that's where the communication piece is so important, because the neurologist is going to be meeting that patient similar to you are for the first time. And so they need to know as much about the patient's quality of life as they can. So is there a family member that you know about that you can bring with you? Can you stay to speak to the neurologist and speak to them about exactly what the home environment is? Get a phone number for the nursing homes to be able to actually understand what the quality of life is as well. Or, have that discussion with the patients as well, or make sure the patient's awake enough to be able to communicate that. What we don't want to avoid, what we want to avoid happening is the patient comes in from a nursing home or from a physical, and here's a copy of my ACR. So as part of the physical assessments as well, we have to have, like we talked about on the prompt card, the very first thing of the physical assessment is unilateral arm weakness or drift, slurred speech, or inappropriate words or mute, and unilateral facial droop. So to assess that, to look at unilateral weakness, this is what I talked about before, the pronator drift. You'll actually see patients do this. And so one of the very first things they'll do is they'll actually, if you hold your hands up like this, they'll actually separate the fingers and they'll actually move their thumb out, and then it'll drift, and then it'll fall. In huge disabling stroke, they're unable to get their arm up at all. So there is no such thing as a pronator drift. These people are completely hemiplegic. Well, that qualifies. But certainly, the first thing you will find, and this sometimes can be very subtle like this. Occasionally, when you examine their faces, well, you will see that they actually have loss of the normal curves we have here called nasolabial fold. I'm pointing below my nose into my cheeks. You'll actually see that one of their cheeks are flattened. Or as they breathe, part of their cheek actually puffs out as they breathe in and out. Those are subtle signs. So the not so subtle signs that I've seen come in from nursing homes is sometimes you'll see patients that actually have some of their food trapped in between their buccal mucosa and their mouth, and they're actually from yesterday's food, and no one actually picked up the stroke, but you look in there and you're like there's a half-eaten sandwich tucked in between their molars and their cheek because they lost that normal buccal pressure they have with their cheek, and things just accumulate there. Standing with your legs, have the patients lift their legs 30 degrees and hold for 5 seconds. Now, for those of us that don't have a lot of ab muscles, that's a bit of workout. We've got to do that, especially if you're supine and lying there in bed, and if you're 90 years old, it's kind of hard to lift that up. But the key is it symmetric? Is one side equal to the other? And that's the key to be able to pick up. Now, the third speech. Third speech is another gray. It's one of those other things that's hard to sort of understand if this is is it related to something else, or is it related to, like, what do they normally speak like? People always accuse me, and for those of you listening to me today, I mumble a lot. So I apologize if I'm mumbling, so if you're having a hard time understanding. My wife always asks me, like, every time I say something, she'll be like, what are you saying? Because I just apparently just mumble along. So the key is that a change? Did the patient always talk like that, or this is a new change? And so that's where the historical element with the family is so important as well. One of our neurologists, one of our emerge physicians who's from Newfoundland, always assesses patients, and he has them repeat things when you assess them. He'll always say, I want you to repeat after me. And I'm not saying this has to be the catchphrase, but he always says, the Royal Newfoundland Constabulary. And when he says that, there's so many consonants in that that actually brings out some people's slurring of their words. So you'll see these lovely little old men and women going, oh, you're like mumbling. But maybe you'll say yes and no questions very well. Yes, no, I live in Dutton, I live in St. Thomas, whatever they want to say. They can say those words quite well, but they have a hard time enunciating constabulary or something else. So some other words. Identifying patients, identifying words, objects may be another useful thing. Like, what is this? This is a belt. What is this? It's a pen. What is this? It's a watch. Those types of things they may be able to have. or they may be able to lose different things. So they can actually carry on speech with you, and it's always very powerful when you're examining someone. My medical students sometimes will go see patients and talk to them, and they'll come back and say, "Do you think they're a reliable historian?" And they'll be like, "Yeah, they told me all about this, this, this." And I'm like, okay. You walk in and talk to them and go, "What day is it?" And they're like, "June." Like, no, what day is it? And they're like, I don't write many letters. Like, no, I want to know what day today is. And they'll be like, "I have no idea." And they'll tell you it's like Tuesday. It's actually Friday. And they'll be like, "Okay, well, what month is it?" Like, they don't know. And then you'll ask them, what season is it? And then what year is it? And many of them don't even know the year. And so then if you're trying to figure out, is it a chest tightness or a chest heaviness, or is this these fine little points we ask about in terms of historical points, if they don't know the year, they probably aren't a reliable historian. These are important sort of points to pick up. So you may be able to have a conversation with someone, but if you actually name an object, what is this? They won't be able to get it for you. They'll be like, that is a, and they know, and it's an expressive aphasia. They know what it is. They know they want to say pen. They'll be like, apple. You're like, nope. So those are some of the most subtle things we actually have. So you can actually get them to try and remember 3 things. I don't think we do that a lot in pre-hospital. We definitely do that in emerge a lot. We'll say, I'm going to name 3 things. I'm going to come back to you and ask you in about 2 minutes what these 3 things are. It's part of our mini status exam. So then we remember pen, apple, and chair. And they go, okay, pen, apple, chair. Got it. Okay. And then you'll ask them a few more things. So you'll ask them to spell the word world backwards and a few other things. Do a couple math tests, like subtract serial 7s from 100, a bunch of other different small things. After about 2 minutes, you go back to them and say, what were those 3 things we wanted you to remember? No idea, many of them. So that's another sort of mental status thing you do. I don't expect that to be done pre-hospital. What we're looking for is that the only take-home thing about speech, which is, are they slurring their words, and are they having a hard time naming things, or are they mute? Those are the keys. Where we get into trouble with this before is you walk into a bar. Someone's sitting there, they walked in, they seemed fine when they were there, the bartender fed them 10 drinks, and now they're slurring their words. By the wording of the prompt card, they're not slurring their words. They may now be able to qualify, but we need to sort of get some sort of history. If you've just fed that guy 10 drinks and he was last seen, well, 2 hours ago, but there's been 10 drinks in the interim, maybe he's not having a stroke. Maybe, and then that's where you sort of look towards the motor deficit. Is there some other motor deficit? But then they are uncoordinated with their gait. So yeah, but maybe they're intoxicated. So these are things that I'm not saying there's a right or wrong answer here. It's possible you have a stroke sitting at a bar. It is entirely possible. But it's sort of that, if you're going to do that, though, let's bring them and bring them to the hospital, give them every chance of therapy. Let's stay and let's make sure that you provide that history and say, look, I know, speaking to the bartender, speaking to the patient, he had 2 drinks, and this is clearly a motor deficit that he has, and this is a definite sudden change and not a progressive deterioration. At which point, yeah, absolutely, give them every benefit of the doubt. There are some tips on facial droop that we talked about as well, and that's also hidden the smile. Sometimes you'll get them to smile and they'll actually unable to move one side, and that clearly shows. Or to get them to grimace their teeth or move and show you your teeth, or get them to stick their tongue out or try and open their jaw or trying to open their eyes. This slide here is trying to show you that if you get them to close their eyes very firmly, you can actually try and open their eyes. One eye will open very easily where the other one is able to stay taut. I'm not saying you have to do that. That's just one of the tricks we use. But most of the ones that are facial droop, we're taught classically that it's dramatic. It's not dramatic. It's just a subtle loss. You'll lose like the corner of their mouth will be down, or their nasolabial fold will be down, or the wrinkles around their eye will actually be different than one side versus the other. Rarely do they actually smile. This whole side doesn't move. It's possible, but it's more the subtle changes you see. Now, blood sugar is a big question. So additional things we want to rule out are presence of seizures. So if you have a seizure, or they seized, or they recently seized, that's a contraindication. The reason for that is this could be Todd's paralysis, like we mentioned before, or also the likelihood of bleed increases. Like if you had a seizure, the likelihood you had a bleed is also higher, and you wouldn't qualify. So and the third thing is you're going to drive them 2 hours down the road and they just seize. Maybe they're going to seize again, and depending on your scope of practice is able to manage seizures or manage advanced airways. These are sometimes difficult situations where you're driving 2 hours in one direction with no hospital until you get to the stroke center, and they continue to seize in status. So we don't want to be transporting seizing patients. Now, blood glucose level less than 3, for sure, hypoglycemia can mimic stroke. So therefore, we know that if you're hypoglycemic, we need to be able to recognize that and treat it. It's interesting how that number is different than our directive. Our directive is we treat less than 4. Sweet. So therefore, in this situation, you arrive and you're less than 3, you're going to treat them. What happens if you arrive and they're 3.4? You're going to treat them by a directive, but it's not a contraindication to stroke. So therefore, in this situation, you're going to do both. You're going to activate, you're going to follow the prompt card for stroke, but you're also going to treat them for hypoglycemia. What you don't want to do is spend 30, 40 minutes on scene, or 30 minutes on scene, giving them dextrose and glucagon, or whatever you're going to give them depending on your scope of practice, and have them go, no, you're still hemiplegic, so now I'm going to activate the stroke protocol, but now you've lost the opportunity to go outside the window. So what you want to do is you treat them and you move them. Let me tell you, that was a big discussion point at Ontario Stroke, trying to figure out what the best plan to do. Because I would prefer it if we, that's my personal point of view, not base hospital, it's just like, well, I think it'd be nice if we had them both coordinate. 4 is the number for EMS, 4 is the number for stroke, but 3 is the number we're going with, so it's kind of like a Monty Python sketch. 3 is the number of counting, and the number of counting is 3. Now, Glasgow Coma Scale. I tell you, one of my favorite questions from my medical students and residents is always the GCS, because it's not the easiest thing to calculate. I know it's I know it's odd, but isn't it funny? You have a scale that goes up to 15, an arbitrary number, but you get 3 just for coming out. Like this table, 3. So it's kind of interesting how poor all of us are at calculating Glasgow Coma Scale. I maintain that, I've seen charts where people are dead with their eyes open, and then they're pronounced with a GCS of 6. Well, it's because you're dead with your eyes open doesn't mean you GCS of 6. So it's important to calculate the GCS. And if we have spent hours and hours and hours, like 7 and 8 hours at meetings, arguing with each other about GCS 9 versus 10 versus 11, let's make sure we're accurate with our GCS calculation. At least we can do. It's the best number for each one, right? So you have to stimulate them enough to be able to get them to move. So I think that I have a much more aggressive approach to stimulating patients than to be able to figure out what the GCS is. So now there's some people are so lovely. They walk up and they go, Mr. Johnson, fix your hand, squeeze my fingers. And you're like, nothing, right? Oh, it's GCS 4. You're like, oh my God, GCS 4. Let me go see them. You're like, Mr. Johnson. Mr. Johnson. You're like, what? And you're like, well, sleeping doesn't give you a GCS of 4. Like, they awoke, they became normal, they're moving, GCS 14. Now, where this gets into trouble here is that if you're unable to speak because of your stroke, you may have a falsely low GCS. And that's why GCS less than 10 was included, because for speech, you have a total of 5 points. So let's say, for instance, you are normal. Like you are motor fine, you are ambulatory, your eyes are opening, you can even follow commands. If this is anything more than 10 and you were mute, you're unable to speak, you lose that, right? So what we're looking for is less than 10. You lose 5 off of 15. You're no longer, below 10, you do not qualify, because there's got to be something else going on. You may have an airway issue that's going to develop, and we don't want to transport you. So that was a painful thing to sort of work our way through. But regardless, GCS less than 10. Now, peds, not a lot of kids have strokes, thankfully, but of those that do, there's usually not an underlying cause of thrombosis. Usually it's an embolism. So if it is ischemic, it's partly embolic because of congenital heart disease, because of arrhythmia, because of potentially septic source, they've launched an embolism. Those type of things are why we tend to see peds. Or it's because of bleed or tumor or alternate diagnosis, like the stroke mimics. Nevertheless, we do know that stroke can occur at all ages, and there are some thrombotic strokes that happen. That's why we still want to include them. The series of this is very small. So if you see a pediatric, I think in our Southwest area we've had 2 or 3 that have actually, I think Children's Hospital Western Ontario has actually thrombolized 2 people with stroke. So 2 pediatric cases of stroke. So it's a very, very small number. But if they're going to have it, it's probably not thrombotic, and that's basically what's stressed. But PEDS is not a contraindication of stroke. So the more, you can imagine, though, depending on the age of the patient, the younger they are, the harder it is to communicate with them. So some of the different historical points may not be there. It's like any challenge with pediatrics. You can't sort of, when I did my PEDS rotations as a resident medical student, I really didn't enjoy going in to see the patients all day long who are unable to find any history. So you're turning to the parents for history, and all you know is this child has a fever and they had diarrhea. And you can ask it any different way, like anything else? No, she has diarrhea. You notice anything else in terms of like complaints and the abdominal pain? Well, she had some diarrhea. You're like, okay, this is going nowhere. So then you're live on investigations. And moving back to adult world, when I went back to working the adult emerge, even though we still see about a 15, 20% PEDS volume, you still need to be able to go up to someone and say, what's going on? And they're like, it hurts here. You're like, oh, this is a lot easier versus trying to figure out what's wrong with the kid. So you're relying more on your physical examination. So looking for speech, looking for motor weakness again, looking for facial droop. But they may not be able to comply with putting their arms up to give you the pointer drift. So you're looking more for the subtle features in their face, or is their inability to speak or their lack of running history truly an inability to speak, at which point you get the parents to be involved, and you get them to communicate. And if they talk with the parents, they won't talk with you. It's a shyness issue as opposed to being a speech issue. So you're going to be a little bit more reliant upon those types of things. Clearly, it's much more difficult on a young child to be able to pick up, but it's also going to be a rare thing. It's kind of like pediatric BSA. Thankfully, they're incredibly rare, but they will occur, and we need to be prepared for them. In terms of the thrombolysis, how does it actually do? What does it actually do, and why are we providing it? Well, we use this thing called TPA, and TPA is a medication which actually destroys the blood clot. It actually chews it up and dissolves it. The benefit here, and this is part of the informed capacity I was talking about before when we talk to patients, is that 30% of people will benefit significantly from the treatment. 50% don't get much better, but 10% may actually have a bleeding complication. Now, bleeding complications can be major, like it can be intracranial and huge and devastating. It can be potentially fatal. But also included in that bleeding risk, there are also things like bleeding from their IV site, bleeding from an arch stab, or bleeding from some of the location like a GI bleed that's from an ulcer that we didn't know about that actually dissolves. So all bleeding complications are included in there. Based on a study that came out many years ago now, we know that you can actually thrombolyze up to 4.5 hours. But your window is 3.5 hours in the pre-hospital phase to give us an hour to be able to address all the things we need to do, blood work, CAT scan, these type of things. The other sort of operational thing that needs to be highlighted as well is that although your window is 3.5 hours and it's last seen normal, that's not your transport time. Your transport time is limited to 2 hours. So what we don't want to do is, imagine you're the only ambulance for a northern area, and you now drive 3.5 hours to get out of that location, and there is no other ambulance covering you, and then you need to drop off your patient, shoot time, clear your stretcher, and also drive back up. And if you're like me, driving 3.5 hours, you got to stop for Tim's, and you got to stop for lunch, and stop about 10 restrooms on the way. When you get back up there, you're gone your whole shift. So that whole area has no coverage. On top of that, you now are pulling other ambulances to cover you while you're out, and you only may have a 30% chance of actually having been thrombolyzed. So really, you're doing all of this. It's about weighing the good for all of the public, not just what's best for that individual patient. So 2 hours is the limited drive time. Those numbers are very important to remember. You're not going to have more than 2 hours. But this is what happens, though. This is the benefit we see. And this is an angiogram taken from someone who's actually had a stroke. And this is actually one of their major blood vessels, probably their middle cerebral. And you can actually see that after thrombolysis, on slide 2 here, it completely restores and opens up. We do something very similar with our heart attack bypass protocol we have in some of the urban centers in Ontario. Is that you can actually see this as well when we actually do an angiogram and then actually put a stent into open people's blood vessels, the angioplasty. You actually see restoration of perfusion like this too, and it's very powerful because we get so used to seeing patients, okay, they have a weakness to their face or weakness to their arm. Great, so we made them better. But think of how much brain is sitting behind slide number 1 here, not getting any blood supply. And think of how much brain now is getting blood supply here. And you think of that impact on that person's quality of life, being able to move versus not. It's dramatic how we're doing, so it's really important work. So, contraindications is TPA, and this is the long list on the prompt card that we talked about before. So there's 3 major criteria you're looking for and a few caveats, and then there's all these contraindications, and we've addressed most of them. But C-test 1, to uncorrected airway, breathing, or circulation, we want to close as possible with these patients. And again, consider this maybe an alternate diagnosis. Symptoms of the stroke resolve prior to paramedic arrival or assessment. So if they are normal when you get there, maybe it was a TIA, we're not bypassing them. Because if they are normal, what is the attempt that we're trying to get by exposing them to the risk of thrombolysis? If you're normal when you get there, we're not going to make you much better than normal, so we're not going to thrombolyze them. So therefore, leave them at the closest hospital. But where the caveat is that you get there, they qualify, they meet the prompt card, you start transporting onto the bypass protocol, and they start to improve en route, you keep going. Once the decision has been made to transport them, you transport them. The difference is that, how do we know they're going to get fully better? And where do we start making like lines in the sand? Like we can't have, well, if they're 50% better or 30% better, or their speech is a little bit better, they get 10 words back, or maybe they're able to move their hand, like let's stop. If they're getting better, you still go, because they may still benefit from some other specialized care at the stroke center, or maybe it's going to come back again. the natural history of some of these is that you get intermittent flow. So maybe they're actually getting a little bit better. They get a little bit of blood past that clot. The clot's still there. And now they're getting restoration of perfusion to their brain, but then now it fully occludes again. The platelets come back. They fully plug that thing up, and now they got worse. Well, maybe you turned around and you went back to the closest hospital. Now you're pinging back to the stroke bypass center. Once they have that, they qualify, they need it, you go. But if you arrive when they're normal, they don't make it. Seizure at onset, that's clearly, we talked about that. Most likely a bleed, maybe this is Hodge paralysis afterwards. Maybe you have an airway issue, you go to local hospital. GCS less than 10, you're probably going to get into an airway issue or an alternate diagnosis, so therefore these go to closest hospital. Terminally ill or palliative care patients, we define that as best as we could, but remember, that's not a DNR. If you have a DNR, I had an 85-year-old guy the other day I was talking about that came in and he had DNR written all over his chart. He came in the emergency department for some other concern. He had some abdominal pain. And he was telling me, even though he's a DR, he told me, I drive my Buick and I got a date on Thursday and I'm going to pick my girlfriend up and we're going to the movies. And I want to get out of the hospital by then. And I'm like, of course you do. That's exactly right. I mean, you can live completely normal lives in your 80s and 90s, and you may have that code status behind you. That doesn't mean we don't treat. So these are terminally ill or palliative care patients. Undeniably, that is a gray. It's a gray area. So that's where history sort of blends in. That's the most people you can have corroborate your story is important, but that's the key. And I mentioned before, duration of a hospital transport will not go over 2 hours. You cannot exceed 2 hours, so don't be driving too far. The bottom line is that patients who show signs and symptoms of hyperacute stroke must be treated as a time-sensitive emergency and should be transferred without delay to the acute care facility that provides emergency stroke care. And that is the bottom line of what we're trying to accomplish with all of it. And we now treat it in a standardized fashion. Is there a question, Nick? Yeah, that's an excellent question. So I'm going to repeat the question for those listening. Anticoagulation. So if you're on anticoagulants, pardon me, is that a contraindication of being transported? So if you notice in the prompt card, it's not a contraindication. And the reason for that is, and this may shock some people don't take their pills as prescribed. So even though we as doctors think everyone's going to, you're going to fill this $110 antibiotic, they're like, yeah, thanks, doc. You're like, okay, everything's good. They don't, because it's $110. And I'm going to tell you, like, I'm super bad at taking medications myself. I'm not fortunate on any, but I had a headache yesterday, and part of that was my own induced from my Saturday night. But I'm thinking, I'm going to take Advil every 4 hours today for my headache. And then about 6 hours after taking my Advil, I'm like, my headache's back. Oh, it's because I forgot to take my Advil. So that's important to recognize that people are non-compliant. So if you're non-compliant with your Coumadin, maybe your INR is low enough that we can still give you, that's the clotting test we look at for Coumadin use. We still may actually have a low enough INR to still actually give you the give you the thrombolytic. And embedded in that question that someone from the web just asked is also they're not met with smiling faces when they arrive at the emerge. You know, and I hear that a lot from EMS. You know, you immobilize them by your spine board and collar, and I got yelled at by this nurse, or I yelled at by this doctor. I brought this patient in under the stroke bypass protocol, but they're on Coumadin, and I got yelled at by the doctor or the nurse. You know, that happens, and I recognize that happens a lot. But that doesn't mean that you're wrong. Sometimes they're just on a bad day, and they're yelling at you, and they got it wrong because they don't know the prompt card, because they don't know that that is not a contraindication. In those cases, that's where our EMS, either affiliation with our service operators or our management, needs to get involved and get them to go back and address that. Or you can involve us as base hospital. I know we've done that. One of our centers kept having, they launched 12-lead ECG and kept bringing 12-lead ECGs into the emergency department. And the docs were yelling at the paramedics saying, stop, I don't know why you're doing this, it's a waste of time. So we went and met with them and said, as an emergency physician, myself, I like getting 12-lead ECGs from the paramedics, because when they do it, they see the patient at their worst before getting the nitro, and they actually have all these T-wave changes in ST segment depression. You can actually see how bad their ischemia is before we take it all away. Before you give them their aspirin and their nitro and their oxygen, and they arrive pain-free, but you don't get that ECG with pain, so you don't know how dangerous it is. And one T-wave inversion is going to make a difference between us admitting them or discharging them. So I think it's a really valuable tool. I'm the guy that said that at their emergency department board meeting, and they're like, that's a good idea. So now all of a sudden, they actually get the 12 leads and sign them and thank the paramedics for the 12 lead ECGs. You can see that that kind of process change actually is an awareness level thing. So just because you get yelled at, that's something you're doing your job, you're following the directives, and actually someone misinformed may be yelling at you. So that's a good question. Another question in the audience here. So I'm going to repeat your question. So I'm going to paraphrase your question if it's okay. Let me know if my paraphrasing is not correct. But basically, there are definitely going to be patients that don't qualify for stroke bypass that need to go to a neurocenter that really may have a bleed. And the bleed may be delayed. The therapy for that bleed may be delayed by taking them to the non-neurocenter, and thus we delay the therapy. So you go to a non-neurocenter, then EMS is being called back to then transfer the patient again later on. And that's a very good point. The bottom line is that there are going to be patients that are going to have that. Unfortunately, that is something that needs to be captured by destination policy. So it can't. The stroke bypass protocol can't be all things to all people. You meet the criteria for this, you need to go to the center that has a CT scanner. And undeniably, you're going to have patients that may have a head injury or have some other sort of mechanism by which you're concerned about the diagnosis of bleed, but by your destination policy, it's the closest, most appropriate hospital, and you got to bring them to like the local hospital where you're supposed to go. And in that situation, yeah, you may get called back to transport the patient again. The only caveat to that is that a lot of the bleeds we have, that we actually don't operate in a lot of bleeds. Second thing is that doesn't really affect you guys, because you definitely have to scan them anyway. But I think that EMS can't be all things to all people, and this protocol can't be all things to all people, and thus have to be captured by destination policy. If you have a situation in your county where one hospital clearly doesn't have CT, a good example is one of our areas has no X-ray, no orthopedics, and if it's a suspected hip fracture, they have a destination policy that says suspected hip fractures go to this hospital, not that hospital. So it is possible to, at a municipal level, to actually develop destination policies for those types of things, and that may be best captured there. Good question. That's a really good question, but we can't capture that in stroke. Good. Okay. So remember, in terms of transport destination, it's kind of ironic. Time is brains. We need to make sure we maximize our efficient movement to be able to get these patients their history and physical done quickly, our prompt card checklist done quickly, and then brought to the closest hospital. Because really, we've got to be able to do this in a very fast fashion to be able to minimize our, give us still time in the hospital to be able to get them thrombolysis. We only have an hour in the hospital, so it requires a lot of coordination by a lot of people. Because not only once you get in our house, we have to actually get the CT tech, we got to get the lab tech, we got the nurses. There's so many different players that are involved in this that we got to make sure we do it all in less than 60 minutes. So, and this basically talks about how it's based on the local ED performance, and it takes us at least 60 minutes in our house, and so therefore you got to bring them to the closest hospital, but don't exceed 2 hours. Now, I think we touched on this as well. If contraindications are found, you simply don't bypass. If symptoms resolve prior to getting there, the closest hospital is the way. If symptoms arrive, if the symptoms start responding, symptoms are better before you get there, and they're normal when you get there, it's the closest hospital. If symptoms improve en route, then you still go to the closest hospital. We've actually met with a lot of the EMS service operators in the Southwest about what does it take to be able to make sure you stay on scene. And we've talked to the ones that bypass. Now, you guys are going to bypass the Goderich mostly, but for those that bypass the LHSC, we've actually talked to them about making sure it's okay with you as a service management that we actually have you stay on in the emergency department to wait for the neurologist to come. We know that the neurologist they're actually told they need to be there within 15 minutes, and sometimes they're actually called ahead, and sometimes they're actually waiting for the medic to get there. But they sometimes have questions that we can't anticipate or you can't anticipate, so we really want you to be able to sit and wait for the neurologist, if at all possible. Quite honestly, if they're there within 15 minutes, your average clear time is 30 minutes, and it takes you a while to fill out your ACR. Most of the cases, the neurologist don't understand how EMS works. You may actually be in the back hall. You may actually be in the in your ambulance crew room filling out your ACR when the neurologist is there, and may not you know how it works. They'll say, is the crew here? And like, no, they left. You're still in the house, actually. And the nurses will say, well, they've gone. But you're actually still there. So make it clear that if you do have to leave, here's the contact information. Here's how you can get in touch with me. Or I am still here. I'll be in the back room with my ACR. So you can have that communication piece with the neurologist. But there may be some sort of questions that they have that you can provide. Finally, you can see in the back of the prompt card we hand out to you here, if they meet yes to all criteria, then they transport. And we sort of walk through each one of these things to make sure you address the contraindications. A good study came out of Toronto looking back at all these different use of the prompt card, and the ones we mess up the most are last seen normal. Last seen normal is the one that we missed the most. So this one here, there's a slide, last time we presented this, that there was an excellent question that talked about consider blood glucose here, the second to last point here, do not delay transport on scene to achieve, yet the criteria have listed as a contraindication less than 3. So really, the bottom line is you're checking your blood sugar. You should do it ideally, you know, as part of your initial assessment. If you haven't done it and you're making a decision to transport to the hospital, well, you have not gone through the appropriate steps in the protocol yet, because you need to know that less than 3 is a contraindication. So everyone has to get a blood glucose done. Simple as that. And you treat according to your standards and according to your directives. I think we've spent a lot of time on this, and I don't want to keep occupying time, but this is the last seen normal time, symptoms and arrival to scene. What the changes do you think are the key for that individual patient? And if there is a member that's around, to be able to use the family member as well. Last time we presented this, I was speaking to management from Middlesex County as well as from Lambton County and also some Elgin County representatives, and they had no reason why there's no operational concerns if the family member is present about bringing a family member in the ambulance with them. I can't speak for Huron County. Bill, you're here. Is there any operational concerns with that? So, for those of you listening, Huron County, Bill Lewis is here, and he has said there is not a contraindication or reason you can't transport a family member if they're willing to come with you as well. I can't speak to that because I'm a base hospital, but if there's no operational concern, that'd be the best thing for the patient to be able to communicate, especially the patient's unable to communicate. And bottom line, Dave, that's pretty much what I wanted to talk about today. There's some case series that we're going to walk through, some case examples, and then we'll be releasing you. But for the purposes of the tape webinar for CE, I think that's where we're going to end it here. Let's know for the questions from the audience. Any questions in the room here at all before me? Any questions, Dave, from the online group? Perfect, great. All right. For those of you that are here, do you guys want to have a little break? And then there's only 5 case series to go through, and then we'll have a little break, and we'll meet about and talk about the case series.
Hi, everyone. It's Dave on the webinar. For those who have been tuned in, I appreciate your participation today. This has been recorded and will be posted on our website later, so if anyone missed it or wanted to catch a couple points, it should be there. But again, thanks for joining in. We're going to shut down the webinar now, and Mike's just going to carry on with the live group here for a little bit. If you've got any questions, feel free to call us at the base hospital anytime. We appreciate your attendance, and we'll see you soon.